Sorry.
Hi, Chris. Hi, everybody. So
Hello.
we're live,
Yes,
and
we
we
are.
have
We
a
are.
few
We are alive.
guests. Yeah. So I'll let you take it from here, Chris.
Okay. Oh, well, welcome back to those of you that have been here before. I see some familiar names, of course. And it is, yeah, this is our first one back after our little summer hiatus. I hope everyone had a good summer. Well, I guess depending on where you are in the world, it might even be winter. But so thank you for joining us again. So today we're going to be covering the walking analysis. It's so the I'll show you a picture here in a moment. And remember, I'm not a podiatrist. So I didn't treat this person specifically for their foot problem, and you'll see that obviously they had a pretty good surgeon that took care of their situation. So we're just using this person as the example, and also because I did set them up in some of our orthotics. So for those of you that are new, this is what we call the recurring webinar. So we do this every month. I use a different case to sort of portray the product. So it's kind of a deep dive into one aspect of the product, either walking, running, or the PRM module. And so I just use a different case. So hopefully it makes it a little bit different, and that's why I think we see some people return to us and we go over this again. But yeah, so I yes, thank you, Ramsey. I had a pretty good break. It was a weird summer. It was very rainy here in the Northeast, up in the United States, and weirdly, like we had more heat last week than we had most all summer, which is good because we get to use our swimming pool a little bit later and longer into the year. So that was a good thing. I didn't get to travel yet though. My family went down to Costa Rica for a vacation. My 11-year-old daughter spent the summer there. My wife's from Costa Rica, so that's why. So she spent it with family. All right, so I am going to share my screen. And I'm going to share the entire screen. And we should pop into a little matrix thing. I think I have the picture up. There we go. How's that? Right in the face. So this particular patient, she's in her early 60s. I think she's 61, something like that. Just a history of bunions or hallux valgus, very prominent on the left. She was a spinal patient of mine before this all happened, but so she was experiencing that anyway. I'm not a surgeon, so I did not do this, but I wish I had a picture of her before she had her surgery. I didn't think about that, but anyway, so this is her left foot. So as you can see, she had a bit of correction, and then this is her more recently. So not bad. It was, she's out in the sun a lot, so she gets very tan. But during the regular year, when her pigmentation color is lower, I mean, you almost can't even see the scars. It's pretty amazing. So obviously, there's still some limitation in her foot. Like I said, she also has some foot problems on the right side too. So we'll look at her analysis here, and so the reason I see her is for her back and neck pain, and she had fusion anterior C4 and C5, approximately 5 years ago. So some limitations, and actually, I was treating her prior to that, and then she was in a motor vehicle accident, and then she ended up in the medical system and in the litigation system. If you're aware of that kind of stuff that happens around here in the United States, but so her car was impacted from the rear, and that's when a different kind of insurance gets involved, and so she ended up having to go see their physicians, and so they said, you have stenosis, and I said, well, yeah, I mean, you didn't get that from the automobile accident. You've had that for a long time. And she does a lot of manual labor. She used to be a caterer, a chef, and just a lot of hard work on her body over the years. And so I used to work on her, especially on her torso, her hips, and her shoulders. Again, lots of degeneration, no red flags or anything like that, but it's just chronic. And then after the motor vehicle accident, she was experiencing a lot more pain. So she went, like I said, she went through the typical medical system. I do not treat uh, patients in that system. It's my choice professionally because I don't deal with insurance companies. And so I couldn't treat her. So she was treating these other people, and she went to, oh gosh, 3 different practitioners, and ended up with injections and all kinds of therapy and whatnot. Just wasn't getting better. She was getting frustrated. Actually, I agreed to treat her, and treated her very, very successfully. But again, it was in the system, and then they had sent her to the surgeon, and the surgeon said, we're gonna do a fusion. And I told her, I said, if you don't change your lifestyle, then this is just going to be the first. And so I predict she'll have more. But anyway, so that's a bit of a background about her. So for those of you that are not familiar with this, so this is the online application. I collect the data with my mobile device. I typically use iPad and a tablet. I use iOS. I have 2 iOS phones, and then I have an Android tablet. I like the Android tablet because it has nothing on it other than my medical applications. So it's not always running. And the reason I mention that too is if you've ever struggled in getting an acquisition, you're having trouble, transferring the data, when people are using their mobile devices. So it's real important they have a good connection, first of all. And then secondly is if you have a lot of other applications that are constantly running, you might get some conflict in the bandwidth, the amount of information that you can send back and forth. And so if you're using a system like this that's collecting a fair bit of data, and especially if you're using the video part of it, you can get some errors just because it shuts down. It's not our system. It's just too much conflict because you got too many things going on. So I tell people, listen, Wi-Fi is typically much better. It'll be smoother and more consistent. So if you have a mobile device that has Wi-Fi and data, I recommend to people turn off your data, and then also turn off other applications that are running in your background. Like when you're trying to transfer this data, you don't need your email being checked, every 30 seconds or whatever, because that creates channel conflict, within your device, and you may run low on bandwidth, and it could stall out. So anyway, so that's a good thing to take into consideration when you're doing this. So I use the online app when I am showing patients or other practitioners, typically. So I'll often collect the information in one space, in one room, and then we go to the computer, and this is where I do like part of the review of findings when I'm talking to patients and showing them the information. You can absolutely do it on your mobile device. You get a lot of the similar information. I just get a little bit more robustness or flexibility here, in terms of how I can look at the data in a little bit more detail. And I just think it's bigger. or you could, attach it to a large screen or something like that. So when you turn it on, this is your dashboard, and here's your account up here that you can actually share this with another person if you want. Over here on the left-hand column, so we've got the home button. You can go right to a list of all your patients. It will show you your equipment. This may look slightly different just because this is my alpha environment. This is where I do testing for the product itself. And the reason I'm using this now is because of the orthotics piece. And then, your settings, you can change your languages. I'm American, so we've got it in Imperial here. As a researcher, we list things in metric, but my patients don't understand the metric system. So we have to use the Imperial system. So I'm going to go back to the home screen. So what the home screen does on this top shows you here, your most recent analyses. And so this one is the person that I just tested. So she actually, and literally just came in yesterday, in fact. Well, the last time she came in was yesterday. So that's when I wanted to test her. So she's been experiencing a lot of back pain, shoulder pain, hip pain, leg pain, and arm pain, all on that left side. And I feel like, especially in some of us in outpatient physical medicine, a lot of this in the US and chiropractors, it's not uncommon that, people show up with what we call everything in the kitchen sink problems. And we kind of work on all of them, just especially if you think in your approach that they're all sort of interconnected. So, and one of them is, she, like I said, she does landscaping, catering, and cleaning, is sort of her occupations. So she's moving around a lot, and we had the talk. We had the talk yesterday because I had her bring her shoes in, and they're horrible. I'm like, you got to take care of your feet. They're one of the most important things, because walking or being mobile is one of the most important things that we can do for ourselves. And so, we talked about that. And the reason I bring that up too is, one, because I find that, footwear is important on multiple levels. And that it's her job, so she should be wearing the appropriate footwear to do her job, not just to do her job well, but to also take care of herself, right? So and I tell patients, I'm like, if you want to keep doing what you're doing, you need to take care of yourself. And so it's not a fluff. It's something. It's like, being a carpenter and having the right tools. This is your tool, is being aware of the appropriate footwear. So the other reason I say that too is I like people to come in with the shoes that they typically wear the majority of the time. And that can be a challenge, as I've expressed, and did a dive into the literature on this, and showing some colleagues that in the Western world, women have an average of 19 pairs of shoes, depending on your demographic a little bit, and men 12 pairs of shoes, right? And we don't wear all of them typically, but it usually revolves somewhere around 5 or so. It's a little bit higher for women. But, if I wear a different pair of shoes in the house, I live in the Northeast, so we get snow and that kind of stuff. So I wear a different pair of shoes when the weather's different. I wear a different pair of shoes I have specifically for hiking, different pair of shoes that I wear specifically, when I'm weightlifting, and a different pair of shoes I wear when I'm walking. So sometimes people will bring in, multiple pairs of shoes, and I'll test them in multiple pairs of shoes to see which one do the best. But the other thing too, and if you've listened to me talk before, is it's my contention that, when I think about using correction devices like foot orthoses, that you have to take the shoe into consideration, because the construction of the shoe, even a running shoe and a running shoe are not necessarily the same running shoes. There could be different drops in them, different things taken into consideration. So I told her to bring in her work shoes, where she experiences most of the problem. So across the top here, we see that, here's her dashboard. her patient file, practitioner analysis, and evolution. So the dashboard will show us, some of the most recent activities. The patient file gives you the demographics and anthropometrics of that patient. The practitioner analysis gives me the listing of the analyses that we've done, and then the evolution. I only have one on here, but I'll use a different example. But the evolution you can do for walk, run, or jumps, which actually shows you graphically all of the analyses that you've done on a particular person over the course of time, so you can show them real easy, the changes that have occurred over the time frame that you've actually tested these people. So when I pull up one of the analyses, it gives you a date and time stamp to it. You'll see also across the top it says orthotics, general, details, filter, and these three little buttons here. So when you're taking the analysis, that's usually when you're going to put in all the correct information. You can go back and you can change that. But it's real important to use the appropriate age, gender, shoe size. And the reason is because the data that's embedded in the system, part of the artificial intelligence aspect of it, is that when we post it against normative data, that's the information that we're using. And then also things like the foot length, we use in some of our calculations, like foot clearance, for example. So that makes sense that, you want to make sure that you get that right. You can also put in, a pain profile of the patient, any walking aids, or their shoe pattern, right? So I'll either typically put that in my notes somewhere so we know which pair of shoes, people were wearing. And, to do an appropriate retest, you probably want them to have the same pairs of shoes on, because, again, if you listened to me in the past, that, different shoes change your walking patterns as well. We go down to the next level. We've got symmetry, cadence, and speed. So this is part of the artificial intelligence aspect of it. Green, amber, and red. Green basically means, yep, no problem. You're within one standard deviation compared to the norm, right? And again, that norm is based on age, gender, and things like that. Amber is between 1 and 2 standard deviations, and then red means you're outside of 2 standard deviations. So the reason for the coloration is if I see green, then I'm like, okay, it's pretty normal. I don't have to, spend a lot of time, looking at things that might be normal, and that the coloration can help draw my perspective to the things where I should probably spend a little bit more time. I was actually just asked by one of the distributors that they're like, can you literally just, film yourself going through one of the analyses so we can show people, that, yes, I take an hour to do this now, but, theoretically, it's kind of like I said, yeah, that makes sense. I said, it takes time to get good at it, but it's fine. People should want to learn how to do new things. And it's like when I was learning how to read, radiographs, x-rays, that, after 7 courses, you get pretty good at it. It doesn't take an hour to read a radiograph. It should only take a couple of minutes. It takes longer to actually, type it up if you're not, transcribing that. So with the colorations, it adds to that. It helps make it a little bit faster. So we see that she's in amber. Okay. I had her on a treadmill, and I do treadmill sometimes when I want to control the environment. So I had her at 2 miles per hour, and I was going to make it go faster, but I noticed she was kind of struggling a little bit. And so I did this for about 40 seconds. She sat back down and she was like, whoo, that was kind of hard. I'm like, well, it shouldn't be. So that was actually, something that we had a discussion about. And I'm like, you should be able to walk at 2 miles an hour pretty easily for longer than 40 seconds. That's for sure. Right. And that her aerobic fitness, which is the base of, basically repair and recovery from surgery, from sport, whatever. I said, that's something you might want to, challenge yourself about. The other thing I noticed is she was not shuffling, but she takes rather small strides, and she's fairly short, but she was taking rather small strides, and so sometimes that could be the treadmill, but in any event, so that data shows up here. So we get your split stance swing. On average, it's about 60-40, 60% in the stance phase, 40% in the swing phase, but it can run the range of being normal in the stance phase between 55 and 65, and 35 and 45 in the swing phase. Obviously, they're inverse related. And it also gives me the stride length in distance. And here, like I said, it's in inches. And then this is going to be your double support phase. I always, I still kind of pop in and look at this. And like I said, I'm confirmed right now. So she really does have a really short stride length. And again, part of that's based on the speed, right? Because I only had her walking at 2 miles an hour. But because, she was kind of exhausted after 40 seconds, I'm like, she probably wouldn't have much better stride length. And then you'll see that, she has a dominance in that stride, especially as you'll see in the swing phase, right? So I would expect to see, a shorter swing time, but my guess is if I had her self-select, she really wouldn't be much different than this. So all of these really would be sort of true red flags. The other thing that I do is I'm like, okay, let me crank this up to what should be normal for her. And that average, is going to be about 3 miles per hour, or 5.1 kilometers per hour. But I'll go a little bit lower because, she's a little bit older, and that, we definitely got to hit that 2.4 miles per hour. So over 3 kilometers per hour or so. And so again, we see this data. I had her walking slow, so I would expect these to be a little bit on the short side anyway. But that's what you'll see when you break that down. And then we look at her trajectory here. So that problem that I showed you in the picture was on that left side. So she still, like I said, does have some limitation in there. And ironically, that's the side she's really experiencing a lot of spinal pain, hip and shoulder pain on that side. And so this gives you the relative. So this is gait line. So gait line is representative of center of pressure. Now remember that the technology that we're using is an IMU, an inertial motion unit. So there's no pressure sensors in there. There's no force transducers or anything like that. So it's an algorithm that's based on foot position, developed from simultaneously using the sensor and walking on pressure platform. So that's how this is extrapolated. So, but it's not as detailed as if you were using a pressure sensor. And as you can see, there's only 4 points that all those averages would go on. So it's not overly sensitive, but it gives you some sense of what that trajectory looks like. That you should basically be heel inverted, calcaneal inversion, or supinated. And then as you go into foot flat position, you should neutralize that. And if you have a good arch, you should not be pronated, but less supinated at least. But the direction that you go in is in a direction of pronation, obviously, but the position is going to be different. So what we get from that is we get the relative percentage of those phases. And again, this is based on normative data in gait analysis. And we see green, amber, and red. So she does not spend a lot of time in toe off. And here's why. When you look at the propulsion rate, so this is a ratio between the hip flexors and the plantar flexors, late stance phase into early swing phase. Okay. We measure this using velocity of foot out, right? And again, it's based on an algorithm with using those two characteristics, the plantar flexors and the hip flexors. Obviously, again, not as sensitive as if you had wired EMG on the hip flexors and the plantar flexors, but you get some actually pretty decent ratios. I use about a plus or minus, 10% on the high side. So when I see 22, 26%, she is definitely, using a strategy where she's not using her hip flexors and really using her plantar flexors. And if you look at this over here, that's why she's really pushing off during propulsion, and this is the result, which is this. I find that people with low back pain, they have a tendency to use this strategy where they use more propulsion in the plantar flexors because it decreases or at least minimizes, the necessary stabilization that's going to go on in the torso, right? Because if you think about, the muscle activity pattern when you're going into, hip extension in walking, it's this sort of cross pattern, right? And so you need to be able to resist that torque. And some of it's natural. I mean, it's necessary for typical gait. But people that don't have good stability, good core stabilization, and in fact, when they're in pain, it's even worse because nociception, even if you don't think about the pain, really changes the recruitment patterns and also results in latency, even in single activity pattern like just a simple leg lift. So you can imagine what it might do to a performance outcome like gait. So you go back up to the top and we click on filters, and the filters, details. So I click on details, and now we get a different set of data. So we get to go a little bit deeper into this. And this is her foot patterning in stance phase, right? When her foot is in contact with the ground, right? So this requires a little bit of description because these numbers are different. Like they're not the same numbers that you would match up against for someone who's walking barefoot or typically, evaluating it that way. And so what this is the sensor. So the sensor has a gyroscope in it, so it knows which end is up, and it's zeroed, right, relative to gravity and the perpendicular nature of the Earth's surface. So this is the actual angle, right? The actual angle relative to the ground, right? And so because of where the sensor is positioned and it's not, I always refer to people just to make it easy that it's like using the foot and lower shank as a block model, but it's not totally that. So there's a slight integration there of the mid forefoot, with that triplanar, activity. But in any event, in our system, and this is where it is basically proprietary, is we've identified the specific walking pattern. And this is what kind of confuses people because they see pronator, supinator. Well, if you look at the trajectory of the foot in a shoe relative to the ground surface, this is what it looks like, okay, based on putting an IMU on that person. So what we've been able to do is create a normal pattern, which is what you see here, this green corridor, and the width of it is the standard deviation of the normal. Now, what we see here, when I put my cursor over these points, these are actually the subject's data points. So negative 17 degrees. So a negative implies that it's going to be a heel inverted position. A positive angle means that we broke neutral, and now it's going to be a heel everted position, okay? So keep that in mind, because as I look at this trajectory, I'm at negative 16 when the toes come down and you're in foot flat, right? So that has something to do with the foot position relative to the Earth's surface in a shoe. And I keep saying in a shoe because maybe that shoe has a weird sole to it, or, a very thick construction, whatever the case may be. The other thing with this particular person is she has genu varis, so she's slightly bow-legged, as we call it. And so that often impacts what's going on in the foot. And we can see that even if you don't know what these numbers mean, her trajectory is not what's considered to be normal, which is what we see here, right? She falls within the normative range and she heel strikes, but she stays on the lateral aspect of her foot all the way through. And even in her toe off position, and we saw this, hold on, I'm going to go back here for a moment. We saw this on gate line. Like, she does not really do a good transition over to the first and second metatarsal region, right? And so we're seeing that she's definitely on the outside, and that's what we also picked up over here. Whoopsie. Okay. Now, the numbers that I get on either side, the min and the max, that's actually the standard deviation. And so she's got a 3-degree standard deviation on heel strike, 2-degree standard deviation on foot flat, and 1 degree here, and it opens up a little bit more here back to the 4 degrees. So the standard deviation is something else I might look at. If it's either too tight or too wide, then that's potentially a problem. And then we look at her other pattern here, and she's within the green, and I don't like to tell people to get hung up on the coloration, but look at her pattern. It's curved linear in a fashion, if you connect all these dots, right? So she heel strikes with a relatively flat foot here, but it falls within this point. And I say this because and I think more so the podiatrist will super understand this and probably do a better job at saying, okay, well, I'm gonna maybe do something about that. She does in her standard deviation fall outside of that, and so it's a little bit more less heel inverted than I would like to see. Okay. And again, sometimes that's a strategy that people have when they're trying to reduce certain moment stresses, especially adductor moment stress on the knee joint. But so that's her pattern here. We see very large standard deviation here, and here's why. Is remember that going back to propulsion rate, she's kicking off, man. She's pushing off of her toes to compensate for not using her hip flexors. And I wish I had done a faster speed, but I didn't. She was uncomfortable. I didn't want her. I hadn't treated her yet. I should have treated her and then thrown her back on. But when you're only walking at 2 miles an hour and you're not really stable at that, you got to be careful trying to push people. Oh, one other thing you can look at is you can click on relative. So what relative does is relative brings you down to zeroing at foot flat position. So it's the same delta, right? It's the same difference on these. The reason for this is like, okay, foot flat position. Let's say you did want to compare something relative to like a foot posture index 6 or something like that you're using as another metric, and that's not unusual. This is not the only test that we do, but so if you did want to sort of have a comparison to say, oh, okay, so based on my observation in the static method, she's actually, if you look, nothing changed between heel strike and foot flat position, and that's not typically normal. So a little bit more information that you might want to do something about, whatever it is that you do about that. Often it might be a corrective device or something. So then the foot progression angle. The foot progression angle is the deviation in that sagittal plane, the toe out position, also the valgus position or abduction position, right? So typically, within 2 standard deviations of asymptomatic people, that typically ranges from -2 up to about 14 degrees, right? So, and this is what can be challenging for some people because, yeah, I mean, maybe it falls within the norm, but when you say, okay, well, one side is at 2.5, the other one is at 6.9, they're both normal, quote unquote, but, you know, this is more than 2 times, that distance. And does that matter? In this case, I'm not overly worried about it, but it does explain this factor, what's going on up here. The more you abduct like that, the greater the potential tendency, to heel strike in a much more neutral position. Okay. This is actually not that uncommon, especially people that have a dominance. She drives a lot to her places, and here in the United States, we drive on the right side of the road, so the driver's seat is in the left side of the car, and the gas pedal, the accelerator, is on that side. So it's not unusual that people have shortened external rotators of the hip, and that could be the reasoning behind this. She actually golfs a lot too, so you should have, if you're a really good golfer, you should have a little bit lower foot progression angle, because you should have a little bit more tightness into that, because you do a lot more internal rotation if you're a right-handed swinger, which she is, on this side over here. The other thing that you get here is circumduction. So that's the amount of outward swing, and she's definitely within the normal and very close in terms of the symmetry with regards to that. So I don't really see anything different here. Like I said, that external rotation at 6.9, it's within the norm, but it is different. And I would say, okay, well, that, could be affecting this. So me personally, what I would do, instead of automatically going to a corrective device, is saying, let's just do some stretching and see if that impacts that. And let's figure out if you're supposed to be at 2.5 on this side, or maybe you're supposed to be at 6.9 on this side. My guess is we would probably want maybe to get closer to the 2.5, and maybe that's going to fix this here. But it's not that big of a deal, but I would like to see that normal pattern. I like biomechanics. I like to see how things are moving. So the steppage and the clearance. So this is the angulation of toe off and the angulation at strike pattern at heel strike. It's not unusual. She's got a slightly reduced toe off. And the reason for that is she's walking slow. And I started the beginning of this saying, yeah, she kind of seems like she was shuffling a little bit. And this would kind of, potentially indicate that. And so she really was using a relatively low clearance gait anyway. And then the other thing too was her shoes had a pretty big heel on them, and that's something definitely to take into consideration. But she's fairly symmetrical on the heel strike. Not that much difference between the toe off. I do see this lower angle on the left makes sense to me because of her limitations, where she had the surgery correction on that particular foot. So some other things, if I wanted, I can either create a specific filter. There are some built-ins. So what we mean by creating a filter is I can decide what things I just want to jump out at me on the analysis. And I don't personally do this just because I'm pretty good at reading it, but I can see where some people want to make it a little bit easier. You can, decide which metrics that you want to get out there. It does show you some slightly different graphics as well. The other thing, I'm going to go back and make that by default, is these 3 little buttons over here that if you wanted to rename the analysis, you can also compare 2 analyses side by side, exporting the PDF file. So if I click on that, I should probably explain this picture. I'm a John Wick fan. So, and so this is the printout that I can share with patients or other practitioners. You can also put some comments in here. Okay. X out of that. And then So I think it was last time I did this too. So we talked, well, I talked a little bit about, what we've got coming, and this is the orthotics. If you already have the system, and this is for running and walking, by the way. So if you already have the system, this is going to be there. Not right now. Like I said, this is alpha, but what happens is I don't have to do anything special or different, but I click on this and it's going to generate um, a recommendation for an orthotic. So we have these for walking and running and some slightly different materials. So we've got 3 different levels on the comfort, support, and performance. And I'm missing it here, but this one is recommending for her that she wears the support, which I would agree with that. Like she doesn't need a high-end performance that's very rigid. She needs something with a little bit more control in it. And here's what I think this is cool. And no one else really does this. We have a confidence. This is statistics. So this is based on the data that we use in metrics to generate this profile. It's dynamic, so it's not static. It's based on her movement ability, not her static ability. And it gives us this confidence level that that's going to be it, which is pretty cool. And I've been asked, they're like, well, is 78 good? It's very good, actually. Because over the counter, and I do this a lot with patients, like if they weren't wanting to spend money, I'll usually send them someplace else anyway if it gets to that level of detail. But it's a bit of a challenge to find something that's going to fit both your right and left foot over the counter. So these are actually semi-customizable. They're thermomoldable. I don't know if you can see that, but so these have actually already been done and fit. These are actually mine, and so they're fit. And this is where those of you that know how to do this kind of thing, you can overcorrect, you can undercorrect depending on what it is that you want to accomplish. And then it also tells you where to put the postings, which is pretty cool. So it uses the description here and then also shows you a picture to make sure they go there. I think some people are challenged with this, and they need to look at and make sure that yes, this is in fact the left foot, and that's where we're going to put the postings. Why? I'll show you back in a moment, but so I have sets of postings. I don't have the fancy boxes yet because I just don't. They haven't given me any. So we've got some different widths of posting, so you can kind of decide, what you would like to do about that. I can't get into a whole lot more detail other than that, but different constructions, different areas. It's why they're different colors in different areas. Those of you that already do orthotics already know this kind of stuff. But like I said, it's semi-customizable. So the thermomoldable, 3 different levels that we're providing the recommendation, and then the postings. And so I think for each set of walk and run, you've got, I don't know, it's like 250 potential combinations. And so and the price is pretty good it's very, very good for a semi-customizable. So it's already part of the analysis, which if you're already doing this, it takes you between 30 seconds and 2 minutes that most people tend to do this. I'm already doing the walking analysis on my patients. I click on orthotics, it generates that, and you can thermomold them and attach the postings in about 5 or 6 minutes. So pretty cool. There is going to be an orthotics module only offering, from what I understand. I hope I'm not speaking out of turn, but again, if you're already doing analyses, then it's already there. So it's based on the dynamic data, not on the static data, and we've had some pretty good luck so far. So let's see, did I cover everything? I think I did. Yeah. All right. I will hit my stop sharing button. Gosh, I think last time, what did I talk for like 15 minutes before I realized that I was the only one listening to me? Um, let's see. Uh, Theodore, sorry, we're seeing measurements before the operation. No, so I didn't have any before. This was only after the fact, so I don't know. I didn't test her before she had surgery. I wasn't that wasn't my treatment for her at that moment in time, so I don't have any of the pre data. Um, and then next question, can you please repeat the planes on which the angles are defined and plus or minus meaning? Yes. So I think you can see this will help a lot. So this is my right foot, right? So when I ground contact, right, I'm going to land on the outside of my foot. So that's going to be inversion, right? So inversion is going to be represented by a negative angle, right? So I can call that negative, I don't know, 20 degrees, something like that. So negative, and then as I go into foot flat position, and now I'm in more neutral, but hopefully you can see that there's still a little bit of cant there, right? And so now I'm at, -8 maybe, and then I'm going into heel lift, still a little bit of cant. I go into toe off position, and again, it's not just represented in the heel, it's an algorithm that we're working between the midfoot and the rear foot. So that's the reason behind that corridor. So these measures are in the frontal plane, right? Like ab and adduction, relative position. And then you do get heel strike and toe off angles that we saw on the foot clearance metric. And those are obviously in the sagittal plane. And remember that the numbers that are being represented, they're the numbers relative to the Earth's surface, right? So if a person's foot is like that in a shoe, it's going to represent a negative, 20 degrees, right? And that's why I say that, if you have a really high arch on the shoe, because this goes on top of, the shoe construction, you do take their insoles out if you want, if you can, fit everything back in. I wanted to retest her, but I couldn't put them over um, I couldn't fit these in her shoe with her foot over the orthotic, or these are the orthotics. I couldn't fit the insole tester over the orthotic inside her shoe. I showed that last time, and it exacerbates the angulation a little bit, but you'll still get that appropriate pattern. How do you find the angle of foot strike changes depending on heel strike as it's calculated by the angle rate? So it's actually literally that sensor, right, is running parallel to the insert, and it's literally that angle change relative to the Earth's surface. So you are correct that if I'm in a shoe that has a really high drop to it, that angle is already going to be slightly exaggerated, even when I'm just, standing. But we're not measuring that in foot flat position. But what you are getting, if you care about this, is the surface of the shoe relative to the ground surface. Now, it's not the angle of the tibial calcaneal joint, unfortunately, but it is the angle of the shoe's flat surface, or I should say the inside of the shoe under the foot. So what we can extrapolate from that is if they do have a really high heel or something like that, it is going to, potentially impact that. We don't zero it. So literally, if they're just standing there And when they toe off, that's not going to be as much impacted as they're going to be on heel strike. So heel strike might be a little bit more impacted, but again, it's the angle of what's inside the shoe, not on the outside, even if they're wearing a heel, if that makes sense. Any other questions? Roadmap of what, Theodore? Oh. We're this close. I am actually, they're on their way here. I am receiving what we think will be the last round of samples. So we've gone back and forth many, many times. We've had some of our distributors who also in the podiatry space and the physio space that have been testing these, and I think we're coming down to that one consensus of where we are going to figure this out. And so, as long as everything goes well, I mean, hopefully we should be able to move forward very quickly. Well, as quickly as corporations can move, and definitely see this by October, November, something like that. Like hopefully be in production and in the hands of practitioners. What about sports application? So I'll give you a general, and then if you have a follow-up, a little bit more specific. So for sports application, so I do running analyses on athletes and whether they're a runner, and so I always do a walk first because walking has normative data to it. So as far as the sports application piece goes, I mean, you can get a sense of, you can do a gait analysis on their running. We do have some normative data when it comes to running, but more so it's you'll need a little bit of a background in the running aspect of things. And then there's what's called the PRM, or the performance rehab module, which includes a single horizontal hop, a triple horizontal hop, and these are single leg. There's the side to side, the 30-second side hop, and then there is the counter movement jump, which is 2 feet bilateral, and we get lots of characteristics there. And I'm pretty excited because the literature, the research is really moving very hard into, it's not just distance, but it's actually looking at motor control patterns. And I've got a research cohort. I've got 5 students in my program that we're looking at doing some very specific detailed analyses, including, so for example, whenever I have a runner that maybe shows an increased contact time on one side, I often do vertical jump testing to see if it's a problem. In other words, they don't have the strength to turn that over. And I can do another, rapid jump testing. And that's actually where the triple hop comes in, because you can actually calculate a reactive strength index from the triple hop because you've got 2 ground contact times. And so you can use that as a metric, but you also get to see, and compare the symmetry between side to side on all of those characteristics. So we will definitely do a follow-up performance rehab module, one of these in the very near future.
Chris, there's one question in the questions tab by Ramsey.
Yeah, that's what I answered when we were looking at that heel strike position. So um, the heel height, like I said, it does make a difference relative to the surface of the shoe, but the angulation is going to be between the foot and the surface of the ground, because on that first heel contact strike, you know, the sole of the shoe can certainly make a difference, especially once we get into that contact. The length of the heel can make a difference. So again, that's something we have to contend with, and why, you know, we either choose, if you want as close to normal data like something barefoot, then you know they have to wear like a low profile shoe. Some of us have played with using like yoga shoes, little booties, things like that. That they need to be, you know, secure in there, or using a low profile shoe, like I've shown a little bit in the past, that has no drop to it. There's no cushioning on the heel. So that's those are kind of the best ways to get as close to that neutral position when it comes to that. If you ask a client to do 6 hops from an endurance athlete instead of just 3, would the system measure? No. and so here's why, is because it's all algorithm based. And that's how we get the metrics, because we don't just collect raw data. So we actually run the calculations, and the calculations are going to be based on 3. So it actually, if you attempted to do 3, because remember, every time you stop a test, whether it's walk, run, or any of the jumps, they have to be completely stationary. So they can do the 3 hops, and it only collects the first 3. And in fact, what I found is sometimes you'll get an error because it's detecting too much aberrant motion. So unfortunately, it's very specific. And here's why. We didn't make this up. This is the test that's in the literature that was designed and validated for this very specific purpose. And that's why. So we kind of stuck it to that. We're messing around with, you know, is there a way that we can potentially do raw data? You know, can I just get 6 hops, for example, and maybe not get everything? And so it's a little more, it would be a different test, but it's potentially possible. I would like to do a single leg vertical jump counter movement jump test. And so we're in the works of trying to figure out, you know, what else that we can add that will add more value to people. Yes, this will be recorded. Alaya Raja. I don't know if I pronounced that correctly, but yes, this is going to be recorded. Can you try rubber C shoes for neutral gait? Like I said, yeah, I mean, I wish I had some of what I use sometimes. The only problem, whatever it is, so you can use any kind of shoe, replicate, you know, to replicate or pre and post test, then, you know, you'll do it again for sure. But yes, you can use any kind of shoe that basically will fit the sensor insoles, right? So there's, you know, very little to them, and so I've been able to use them in like I said, the yoga. Yes, so I have Vibram 5 fingers. They're a little challenging to get on sometimes, and then also the New Balance neutral shoe, low profile shoe. I've showed that in the past, so that uses a Vibram sole as well. Yep, absolutely. All right, it is the top of the hour. Normally I can stay on, but I actually have another session at 2, which is 2 o'clock my time. So I think it's like 8 o'clock your time. Metrics different for sport performance and rehab? No, they're the same. They're going to be the same metrics. It gives you the same output. And I haven't really seen where it might be different, because we always kind of post things against normative data. But yeah, So in other words, it's the same test. It's the same metrics that if I was using this for performance testing or, baseline testing before the season or before training or something like that.
I just wanted to say for the person, Elia Raja, who asked about the recording of the webinar. So in fact, with the same link that you used to access the webinar now, you could click the same link after the webinar and you'll be able to get to the recording or to the video replay. Also, we will add this by tomorrow evening. It will be on our YouTube channel. So you could reach us there. Also see this webinar and the old webinars as well.
Cool. All right. I do have to run, but thank you all for attending, and we will look forward to the next one.
Okay. Thank you all. Thank you, Chris. Have a nice
All
evening,
right.
everybody. And don't hesitate to reach us if you have any questions. Have a nice evening. Bye-bye.